Okay, good morning, everyone. We'll get started. So before I introduce today's speaker, just a couple quick announcements. Next week is going to be our last grand rounds of this academic year. It'll be Dr. Michael Compton, and then we take a month off for August, and then we'll restart again in September. One piece of great news. A new R1 grant came in to Dr. Francesca, I'm going to butcher this name, I'm sorry. There you go. A 4-year, $1.8 million R1 grant entitled Non-Invasive Quantification of Brain Glucose Metabolism Using a Portable Positron Emission Tomography Camera. So portable PET scanning, which sounds very, very cool. Okay, so today's speaker is our very own Dr. Barbara Stanley. Dr. Stanley is a professor of medical psychology in the Department of Psychiatry at Columbia University. She's also the director of Suicide Prevention, Training, Implementation, and Evaluation Program here at the Psychiatric Institute, and is also a visiting professor at the University of Oslo at their National Center for Suicide Research and Prevention. Dr. Stanley's work has been recognized with many honors. She's received honors from the American Foundation for Suicide Prevention, the Suicide Prevention Center of New York, from NIH. She has authored over 180 peer-reviewed publications, and we are very excited to hear her talk today entitled Zero Suicide Initiative, Mission Impossible.
Thank you. It's nice to be with the home team. So today I am going to be talking about the Zero Suicide Initiative. So how many of you have heard about zero suicide? Okay, so about half of you. So it's when we go out to any of our suicide meetings, that is basically all what people are talking about. And I'm going to talk a little bit about the background of it today, and a project that we're doing together with OMH. So. These are my disclosures. We have funding from NIMH to do some of the work that I am going to be talking about today. We also have funding from SAMHSA. The work is also funded by OMH. So I am going to be talking about a lot of numbers, presenting a lot of numbers and facts and figures. And I thought I would start out with us just taking a look at the people. These actually are some of my favorite celebrities who have died by suicide. So the people that you may not know are Diane Arbus, Sylvia Plath, Mark Rothko, one of my favorite painters, and so this is pretty esteemed group. And down here in the corner is from my youth, Don Cornelius with Soul Train. He also killed himself. And so, so these are the celebrities. But I thought I would just start with an email that I received last week. I get these emails, and those of you who do research either on depression or on suicide or on schizophrenia probably get these emails too. So the email says, I found your link on the Center for Suicide Research and Prevention website, and I've also watched a few of your speaking events on YouTube. The reason I'm reading this is because the celebrities take center stage when it comes to suicide, but these are the people who I deal with all the time. They're not the celebrities. There are brothers, our sisters, our next door neighbors, a child that your child goes to school with. There are parents. So the email goes, our 15-year-old daughter, Claire, ended her life the last night of just ninth grade 4 years ago. In Claire's case, there was no substance abuse, no family dysfunction, no bullying, nothing extreme except internal pain, and we did not even know she was depressed until we read her suicide note that fateful night. What happens in the brain when pain becomes so intolerable that the switch we are all innately born with to survive turns off? Are we not all born with this trait to fight to stay alive? Why do people even facing terminal illness fight to stay alive, yet the suicidal mind will not? Each day is a struggle to make it through, knowing her pain, what her pain must have been. As another teen wrote, like having your leg on fire. And then she just ended. She had written a song dedicated to her daughter that she sent to me. And so this is why we do what we do, because we, and in fact, in our group in molecular imaging, this is what we talk about all the time. What stops us from wanting to stay alive? So I'm going to spend the rest of my time with facts and figures, but I don't want us to forget about the people. Okay, so suicide is the 10th leading cause of death in the United States. We're really in a bad place with this. We have about 123 suicides each day in our country. A lot of Europe, the suicide rate is going down, so we're kind of different in what's happening in our country. It's the second leading cause of death in young people. And interestingly, over the last, say, decade, things have kind of shifted to where the highest age group of suicide is the 45 to 64-year-olds. It didn't used to be like that. It used to be the old white male that would kill himself. So this is predominantly a problem for white people and predominantly a problem for men. Suicide, not just suicide attempts. And then over 1 million suicide attempts occur. This is an estimate annually in the US. There's about the ratio is about 25-1 of attempts to deaths. But what's interesting and important for those of you who work with older adults, the attempt to completion rate is 4-1. So that if somebody who is older tries to kill themselves, they're more likely to succeed. There are fewer attempts per death. So while not directly relevant to this talk, I know that it's very much in the news these days. Drug overdoses, which are not classified as suicides, have killed over 6,300 people last year, the last statistics that we have. So if you total 45,000 and 63,000, we have over 100,000 people dying by what is now called lifestyle deaths, so things that are basically self-inflicted. Nearly 2/3 of the ODs involve prescription or illicit opioids. And this also, like suicide, is also going up. And so what is really interesting and important here, I think, is that over the last 15 years, major causes of death in our country have gone down. So if you look at heart disease, it's amazing what has happened over 15 years. And so the mortality rate has also all causes mortality has gone down. But then if you look at what happens with what's happening with suicide, it stands in stark contrast. And if I put on drug overdoses, it would look pretty much the same, although it might have a steeper incline over here. And so this is unacceptable, basically. And so we've been looking at, like, where do these suicides, where do we find people who are suicidal? They're just out in the world and they go off and kill themselves, and we haven't detected them. How can we possibly help them other than have a campaign to say people should ask for help? But in fact, they're in our healthcare system. we have touched them. And so about 80% of people who die by suicide had a healthcare visit in the prior 12 months. 45% who died by suicide had a primary care visit in the month before their death. 19% had a contact with mental health services in the month before their death, and 10% had emergency room visit prior to their death. And of course, the risk of suicide death from psychiatric inpatient discharge is great. So zero suicide, the Zero Suicide Initiative, and this is actually really important, focuses on suicide within healthcare. It's not trying to make zero suicide. Of course, ultimately the goal would be this. It's not trying to say, okay, we're going to have no suicides ever. What this is saying is we are going to try to have zero suicides for the patients who we touch, who are in our system. And so this just looks at some of the New York State surveillance data. And this is from a couple years ago. So about 30% of people who died by suicide in New York State had discharge either from an ED or an inpatient within 30 days of their death. So that's a lot. And 21%, it occurred within 7 days. So this says, couldn't this be, especially this, or even this, a point of intervention? And that's one of the things that Zero Suicide addresses. It talks about transitions in care. What do we do between the transitions in care? So our former commissioner of the Office of Mental Health is actually one of the biggest proponents, and he was in fact one of the developers of Zero Suicide along with David Covington. And so this is what Mike Hogan said: suicide represents a worst case failure in mental health care. We must work to make it a never event in our programs and systems of care. And so he had a very, very keen interest when he was the commissioner in reducing suicide, and he still has that. So where did this name come from? And I'm going to talk a little bit about the backlash of this name. So this actually came from, there was an initiative within the Action Alliance, and the AFSP endorsed a campaign to reduce suicide rate by 20% by 2025. My colleague, John Mann, said, well, can't we at first just get it to not rise? This is an incredibly ambitious goal, and if we just look at what's happening, I mean, I don't know where they're starting as their base, but I think we're going to fail. And so the foundational belief of Zero Suicide is that suicide deaths for individuals under care within our health and behavioral health systems are preventable. And it's really important to remember that this is an aspiration, an aspirational challenge. So the notion about this, why focus on healthcare? Why not just go out there? Because if you think about it like statistically, it's an enriched population. It's where, it's like, as David Covington would say, it's kind of the so-called low-hanging fruit. It's where we kind of know that suicidal people are. There's a much higher rate of suicidality in certain populations within healthcare. And so it's saying, okay, so we already know these are groups at risk. Let's just go there. Let's go within the healthcare system. In addition, the Joint Commission had a Sentinel event alert that says that that suicide ideation detection, screening, assessment, safety, treatment, and discharge should occur for all at-risk individuals. So there's been some backlash to this. This is one article. There's a couple others that says there's skepticism towards the idea. In Sweden, it's called Vision Zero, and there are lots of arguments against it. Mostly having to do with, are we going to be more responsible, and are we setting an unrealistic goal? And in fact, we just got this back last week, and I asked Yael Holishitz if I could put this up. We wrote an article, Yael is the first author on it, about implementing zero suicide within residency training. She did a lot of work with this, and And the reviews actually were really positive, but the editor had this comment. Although the authors mention in the penultimate paragraph that the perceived connotation of zero suicide may represent an unrealistic goal, the editors, who were actually nameless, request that the authors be far more definite here and also make this point early in the manuscript. Of course, a goal of zero suicide is unrealistic and contrary to the available evidence. I was pretty shocked to get that in a review, but if this editor said this, a lot of people feel this kind of standing back from this. So I'm not going to say more about the name. The name is the name. And I'm going to talk about what it is and what we've been doing within it. So I got this from Mike Hogan. He loves this Swiss cheese model, but it really is, it's actually really very, very good because it so completely portrays what happens to our suicidal patients within the healthcare system, which is they slip through the cracks, or here they slip through the holes in the cheese. And if you think about it, if you think about this from the point of view of like what happens when somebody goes to the ED and gets for a suicide crisis. They've made a low-level suicide attempt, and they decide that they do not need to be, the staff decides they do not need to be hospitalized, and so they send them home. So what happens when they go home? What do they go home with? Who do they go home to? And so, we already know from all of our data that if you make a suicide attempt here, you are at elevated risk for the next 3 to 6 months for another suicide attempt, at least that period of time. And so, so this is really addressing that. And so here are the kinds of things that we need to do. So it's act, engage, reduce lethal means, treat it, and support it where needed. So, but the point is, our patients slip through our cracks. And so here are the 7 elements. I'm not going to go through each of these elements, but because I want to go on and talk about the project that we're doing within New York State. So there are 7 elements that the Zero Suicide Initiative has identified. These wouldn't be that surprising to people who work on implementation. So there are 3 elements that relate to implementation, like how do you get it to happen? And then 4 elements that relate to what we should be doing with our patients. And I have been focusing, as a clinician, I focus on these 4 elements, what we should be doing. But what I have learned very quickly is that if we don't address the other 3 things, we're going nowhere. And so this project, which is gigantic, is my first foray into implementation science. And it's been quite an eye-opener for me. So, okay, so the first element is called LEAD. And so this is like a kind of a no-brainer. It starts from the top down. You have to create an organizational culture where suicide prevention is a priority, and suicide is everybody's business. And so what they're talking about is really from the top down. And so they're working with very, very large healthcare systems, not just behavioral health, where they want the head of that healthcare system to endorse this. We have to develop a competent workforce, and I have some data on what the competencies are in New York State. And then the other implementation element, of course, is to improve. You use data on an ongoing basis to give feedback and change and improve. So what are the 4 elements that they identify as important? And what's really interesting about this is like what I would consider to be the floor of what we should be doing for suicidal people. This is your basic. This is nothing fancy. So first we have to screen and assess suicide risk. We have to figure out, okay, we've identified somebody who is at risk. How do we get them into care? we have to do something with them that is going to help them. And then we have to help them with the transition. Again, that's that kind of like space between one part of care and another, or leaving care. And so we have developed a model that I'll talk about, the AIM model, that takes these elements and translates them into how we actually put them into practice. So where did zero suicide, what's the come from, like in terms of the data supporting it? There was in Henry Ford, and this is a recent article, but there were other articles that were earlier on, but this is the most recent description of it. So Henry Ford Hospital in Detroit started this perfect depression care for the entire system. And they found that as they were doing this, they noticed that their suicide rate within their system went way, way, way down. And for a few years, they had no suicides, and it had been pretty high. And so that's one piece of data. And so then people looked at, okay, so what did Henry Ford do besides develop a car? The zero suicide evidence base further, and I say here it's not too deep to date. We don't have a lot of evidence. The other place that they look to is Centerstone, that implemented similar things to what Henry Ford did. Suicide screening, risk assessment, clinical plan for managing risk, follow-up, and ongoing evaluation. And so then they developed a pathway for people who were at risk. And they used the CSSRS. And they found, again, that the number of suicides went down. That's basically the data supporting the Zero Suicide Initiative. So in response to the widespread adoption of the Zero Suicide approach, because healthcare systems were hungry to do something, and so and it's still happening, they're adopting this approach, they're using it, there's nothing wrong with it, but there was limited data supporting it, and so NIMH issued an RFA to examine its effectiveness, and we applied for it and got it. So this is what we're doing in New York State. And so the thing that I wanted to mention here to this particular audience is that we have developed within our group, and as part of CPI here, this incredible partnership with OMH. Now, we're part of OMH, but often Albany is kind of there, and we're down here. And this is truly a project that this grant couldn't have happened without us. The project and its implementation and all of the infrastructure support couldn't have happened without them. And so this is one of the best kind of partnerships that I think we can have by being part of New York State and having this wonderful infrastructure. And so what we were going to do, what we are doing in this project, is implementing all the elements of zero suicide using the clinical model that we have developed, which is the AIM model, assess, intervene, and monitor for suicide prevention. So that involved universal screening for all clients and higher level of care for people who were at elevated suicide risk. And so the goal is to implement this in about 200 freestanding clinics across New York State, representing over 80,000 clients. It's a gigantic project, as I mentioned. And we were comparing the effectiveness of two different implementation strategies. That's what we're doing. So why New York State? So actually, New York State is either 50th or 48th or 49th in terms of suicide rates for all of the country. We have a very low suicide rate. So in terms of like justifying why we were doing this in New York State, we couldn't say we have a high suicide rate. But when we looked at this, we have, because of the density of our population, we have the 5th highest number of suicide deaths in the country. So even though we're low in our ranking, we carry a lot of the suicide deaths. So here were the aims. So we're using a hybrid effectiveness implementation design and we're looking at outcomes of suicidal behaviors, hospitalizations, and ED visits. And we're comparing these two conditions, which I'll talk about in a minute. we're doing like a kind of a basic strategy, and we're doing a more enhanced, a more intensive strategy to help do implementation. And so why do it in outpatient care? The rate is about 100 times higher among outpatient behavioral health. The suicide deaths and attempts rate are very high. About 15% of patients endorse suicidal ideation in the prior week, and more than half had lifetime suicide ideation, and about 25% made a suicide attempt. So it is a high density population. So one of the things I want to point out here is what we decided to do is, given that there wasn't evidence for zero suicide itself, we wanted to take evidence-based tools and put them together. And then we also, because we're existing within CPI, we had training materials that we had already developed that we could deploy for this project. So again, and these were developed for the state. And so again, this is part of the partnership. And so this was, and I won't go over this whole thing, but we had to develop like this intensive pathway for what happens for somebody when they're not at risk, what happens for somebody when they are at risk. And this is simply our randomization. We randomize by agency. So this is what happens normally. People get assigned trainings to do, and then there are big monthly webinar kind of calls with a couple hundred people on them. And so the enhanced implementation, which we were looking at, which of course costs a lot more and are more labor intensive, is we have site champions who get on calls monthly in very small groups and talk about implementation and get additional training. And so we're trying to see, okay, so do we get differences? We have a number of different hypotheses that we can look at, but the randomized part of this study is comparing basic to enhanced. Those are our outcomes. And so that's our training framework. And so you can see that our model, assess, maps onto the zero suicide model of identify, intervene, maps onto engage and intervene, and then monitor, maps onto transition. So we use the CSSRS in our initial screening. And so why the CSSRS? I asked my colleague Kelly Posner for just a little bit of information about why the CSSRS. This is one of 20 slides that she gave me, but the really important thing here is that number one, there's a lot of validity behind it, but the important thing about this is that the CSSRS asks about individual types of suicidal ideation and individual types of suicidal behaviors. Other scales don't really ask about that. And each type of behavior, surprisingly, is predictive of further suicidal behavior. So if somebody makes an aborted suicide attempt, which is they start to do something, but they stop themselves, they do nothing, they are at greatly increased risk for eventually making a suicide attempt. And so the CSSRS asks these questions. And then, so that's the initial screening part. And then we do a comprehensive risk assessment. We have a module that we have online in the learning management system on doing risk assessment, although they can do whatever risk assessment they are normally using. And then for the part of the intervention, we have them do a safety plan. This is the safety plan. So why the safety plan? Because it's my intervention. But safety planning has been adopted all over the place. And we just had an article that came out in JAMA Psychiatry last week that looked at actually implementing part of the AIM model, which is the I and the M, the intervene and monitor, where we did this in the VA, looking at doing the safety plan in the VA, in the ED in the VAs, and then doing follow-up phone calls with people during that risk period where we said, there is that kind of transition, and found greatly reduced suicidal behaviors in this follow-up and greatly increased treatment engagement. And so Fortunately, we had all of these modules available online except for one where we had to develop what is the overview of this project. So we had all clinicians in New York State, we asked, who were in outpatient clinics, who were in this project, were to take these 3 hours of training. And then we had a couple other optional things that they could take. It's amazing that people have a very hard time finding 3 hours to do trainings. And it's because a lot of these are fee-for-service clinics. If you think about, you have a staff of 20 times 3 hours for each of the staff, that's a lot of non-paid time. This, for those of you who don't know, how many of you don't know about the learning management system here? You all, okay, so we have a learning management system, which I didn't know until I became part of CPI, that should be available for all of us to use. There is a module that we did on the CSSRS. There's a module that we did on safety planning. And there's a module that we did on how to do follow-up monitoring over the telephone. We have a bunch of other ones too. We have one on risk assessment. We're just finishing one that Beth Brodsky is doing on what are the kind of like the fine clinical tools that you need to work with suicidal people and so forth. Okay, so I'm just going to show you now, because we're not even halfway through this project, some of our baseline data for what our population looks like and what our clinicians look like. Okay, so we did a look at our baseline data for people who came into the ED for a visit for self-harm. We went and looked back on what was were they engaged in treatment before they came into the ED or not? And who were they? So we see in New York State, we have, and these are just Medicaid patients, so a good percentage of the people that we have within our system are young. And so how many people who went to the ED for a self-harm event, so they actually did something, they didn't just have suicidal ideation. How many had services within the 7 days? 41%. Within 30 days, almost 70%. 60 days, 80%. So they were within our system. And yet they made a suicide attempt. And so we have to say, okay, so what could we do differently? Is there something we could do differently? And so this just looked at whether they had outpatient visits. And again, what this is showing us is they were here. They were not necessarily within our care we didn't necessarily see them the week before, but we saw them relatively recently. And so this is actually a very interesting point for people who are trying to identify risk factors. So we have been focusing a lot on like the near-term risk, but really it seems like what we should be thinking about is who are these people that, we don't see them all the time. What are the kind of like the little bit further term risk factors that we could identify? And so this just shows where, the ER visits in the prior time. So within 7 days of having made their suicide attempt, 13% were already there. In the last 3 months, over half of them were there. So they had made an ED visit also, and a lesser amount of them had an inpatient care. So we know that they're within our system, they're making suicide attempts. And so what can we do? So we started at a baseline looking at our clinicians. And so in our outpatient clinic, so we needed to establish a kind of a baseline. And so you can see that the majority of people in outpatient clinics are social workers. They all have some sort of medication. So there's like only 7.5% psychiatrists, but every clinic has a psychiatrist that they have as a resource for medication. So this is what we took the workforce survey, and these were the kinds of things we asked them about. What was their knowledge? We asked them actual knowledge questions, their training. We asked them about their clinical practice, and then we asked them a little bit about their organizational climate, which I'm not going to talk about today, but I'm going to talk about these things. So, and I'm going to then also focus on the psychiatrists who were in our study. So 45% believe that generic suicide safety plans should be completed with all patients, even non-suicidal patients. So they had a passable knowledge, but here are like some of the things that popped out, and it's like, okay, well, so that's not what we recommend. 45% believe that treating the symptoms of a patient's primary diagnosis will inherently resolve suicidal thoughts and behaviors. That is kind of an older idea that sometimes happens, but we now think that we should be doing things that are suicide specific. 40% believe that suicide screening negatively affects rapport. This, I think, is particularly alarming to me because it means that people are going to be less reluctant to ask about it. So if you think that the person is going to be upset by you asking about suicide, you're not going to ask about it. Or you're going to ask about it in a way that indicates that you are anxious about asking about it. 38% were unaware that standardized screens produce a higher identification than more informal methods. 38% believe that suicidal individuals, if you're suicidal, you have to be treated inpatient. And 25%, and this was kind of sad, were unaware of the differences between safety planning and no suicide contracts. So they thought that when they said they were doing safety planning, they thought it was the same thing as a no suicide contract. And so then we asked them about what was their training. And so they said that they had, they received, this is the percentage that received no formal training in comprehensive risk assessment, 20%. Discussing lethal means, how to do that, 28%. Dave Lowenthal is developing a module now that will be online about restricting access to lethal means. It'll be in the learning management system too. Creating a treatment plan that was specific to suicidal patients. So that was one of the interesting things. We said, okay, we're not going to tell you that you have to do CBT for suicide prevention or DBT or any particular kind of treatment. Do whatever treatment you would do, but you have to have your treatment plan address the suicide risk factors. You know, almost half said they received no suicide-specific training, no treatment training, and then a smaller amount didn't know how to. Said they received no training in doing monitoring. So these, you know, when we do these kind of polls, or we go out and talk with clinicians, we ask them about their attitudes. So over a third believe that if people who really want to kill themselves wouldn't talk about suicide. So if you think about what does that mean? If somebody is sitting in front of you telling you that they're grappling with suicidal feelings, then does this third of clinicians think that they're not really suicidal? 30% believe that if someone is serious about suicide, there's little that can be done to prevent it. That is absolutely not true. Suicidal feelings have a kind of an ebb and flow. 28% reported they were not comfortable working with suicidal clients. A smaller amount believe that if they talk to their patients about suicide, they put ideas in their head. And so I guess they didn't read Maddie Gould's article that's been around for a lot of years that said talking about it doesn't make somebody suicidal. But at least this is a smaller percentage. And then 14% stated that patients who frequently discuss or threaten suicide don't really intend to kill themselves. And that actually is also not true. So what did they actually do in terms of screening? They all do some sort of screening at intake, pretty much. They ask clients about all types of suicide-related behaviors, in other words, aborted, interrupted, and so forth. About half do that. only about half screen at regular intervals. So the idea is if somebody isn't suicidal at intake, they don't rescreen and ask about it again. And only over a third use the standardized measure. And then this is, so they say over 60% develop a safety plan, but at the same time, over 60% use no suicide contracts. They're kind of like in distinction to each other. 60% contact people if they missed an appointment, which is great. So this probably is because of workload issues, but only about half of them increase clinical contact if somebody is suicidal. One of the easiest things that you can do, it's very hard in terms of people's schedules, is increase your clinical contact during a transition. It can avoid hospitalizations, can avoid suicidal behaviors. A much smaller amount do means reduction counseling. Even smaller amount do use evidence-based suicide-specific interventions. So if you think about this, in terms of where we can go in New York State, we have a ways that we can go. So psychiatrists are definitely more likely than other mental health professionals to have had a patient make a suicide attempt while in treatment with them. So they're disproportionately, and this is not a surprise, given who psychiatrists see, they're more likely to have lost a patient to suicide, and many of them have had experienced suicide attempts of multiple patients during treatment. It is funny, I was just talking with a colleague yesterday, and I said, I've never had a patient who died by suicide. I never worked with anybody who died by suicide. Now that's, when I was doing treatment, that's who I treated a lot. And she said, and she's a psychiatrist, said, that's really startling, and she's had many. And so I think that that's partly who we get exposed to. So what do they have in terms of knowledge compared to others? Psychiatrists have a greater knowledge in terms of screening and risk assessment, but they don't really know more about longer term or brief interventions. This was interesting. 74% of psychiatrists report not having enough training to effectively assist their patient with suicidal thoughts and behaviors. So even though they had more than other people, they still feel like it's not enough. And if you look at what they report as having, how much training they have, less than 4 hours of training. And that what kind of training they've had, they had some clinical supervision, didactic webinar, or a workshop lasting a day or less. So it's really interesting that the field hasn't had a lot of training, and psychology is no different. As a matter of fact, clinical psychologists might get even less training. So similar to others, 36% feel fully comfortable working with suicidal clients. 11%, which is less, thank goodness, believe that people who want to kill themselves don't talk about it. Again, psychiatrists are better off. They don't, only a small number of them endorse the idea that if someone is serious about suicide, there's nothing that they can do to prevent it. And they also don't think that, so in other words, they hold less of the myths. They tend not to use standardized screening in New York State. They tend not to ask about different types of suicidal behaviors. But they tend more to reassess people at regular intervals. And a quarter of them don't conduct a suicide risk assessment at intake. But this was interesting. 15% do not ask about suicide at each session with high-risk clients. So this is one of the things, when you have somebody who you know is at high risk, we always ask about suicide. And again, this probably goes back to the idea that it can impact rapport. 64% of psychiatrists state that they use no suicide contracts. That was a little disappointing to me. But they do discuss restricting access to lethal means. And so they're similar in a lot of ways to the other mental health professionals. So I just want to move for a minute now to talk about, okay, so what practices were in place in our clinics at baseline? So about half of them did post-discharge, post-ED discharge follow-up. They said 70% of them, this kind of goes against what some of the clinicians were saying, uses a standardized tool. They also said they use a safety plan, and they screen everybody at intake. And so these are the kinds of things that they don't do. And these are some of the zero suicide recommended practices. This is not a surprise. They don't have people who had made suicide attempts have input into their policies, and they don't do formal lethal means restriction with their patients. But one of the things that we found when we started to look at our data is that people who had more of the zero suicide practices in place in their clinic and said they were doing it were less likely to have suicidal behavior in the months before, in the 12 months before we started this implementation. So, it does seem like these zero suicide practices hold some promise. And so in terms of implementation, so what we have so far is that about half of the people, and it's not going to go above this, have completed the overview training. 60% did a comprehensive suicide risk assessment training, 58% did safety planning, and then a smaller number did an adaptation that we did for people working with youth, which makes sense. So we started to look at, so are we getting any effects when we do this kind of like extra support, the enhanced implementation, is it making any difference? And in fact, what we're finding, it's a small thing, we're just starting to look at this now, is that clinicians who were in the enhanced implementation condition, in other words, they had these small group implementation meetings every month where the clinician, where their site lead and their site champion attended, were more likely to have done the trainings than in the basic implementation condition. And so then now we're looking at also another implementation measure right now. From when we started to when it was supposed to be fully implemented, you can see people actually are supposed to be doing this, and they are doing it. And you can see the number of positive screens has gone way up. I don't know how people are going to end up feeling about that. But 8% had screened positive at intake now. So that's not a surprise if you're thinking about outpatient behavioral health, that's a pretty low percentage. And so we have to do something extra for that population. And so it's not that much that we're having to dedicate additional time and services to. So one of the things I will just say here, kind of in closing, is, so is it mission impossible or mission possible? I actually think that to implement zero suicide strategies is possible. To have them work, it's really unclear whether it's going to have an impact on suicide. So getting high levels of the staff trained is really difficult. It's very difficult to focus on clinical quality and support when structural issues are changing. In other words, we ask people to do a lot of changes in their EMR, and it's really hard then to do clinical changes too. EI seems promising, zero suicide practices seem promising, and then we have a great infrastructure within New York State to look at these things. This is our team that we have. So this is the group at PI that's working on it. These are our OMH partners in implementation science, and these are within the Suicide Prevention Office here, Jay Carruthers and Sigrid Puchenik, and then we have a couple people who are helping us with our enhanced implementation from the University of Pennsylvania, and we have Mike Hogan and Eric Slade as our consultants. Thank you.
Thank you for that great talk. Very thought-provoking. It's an important area of work.
So I'd like to make a comment and ask a question. First of all, thank you for that presentation, Barbara. It's been a long time since I've heard you give an overview of your work, and it's really impressive. I want to make a suggestion, though, for future direction, which is that I'm involved in a different zero initiative, which is getting to zero, and it's about new HIV infections. And it's interesting to look at that because it's probably gotten a lot more resources, rightly or wrongly, than suicide prevention. And one of the things it tries to look at is not just what's happening in the system of care, but all of the social determinants of health, you know, all of the other factors that impact whether you can get to that outcome. Why do people engage in risk behavior? What's the stigma related to HIV infection, the behaviors associated with it? What is the system doing in it? How do you get through the continuum of care, and why do people fall off and when? And the reason why I'm saying that is this is a wonderful project, but it doesn't take into account all of the many things that probably work against making it a success. One of them is the fact that the State Office of Mental Health is constantly trying to shrink itself. And right now, our staff at the Washington Heights Community Service are under pressure to discharge people in excellent care to their GPs with, just get prescriptions and no real monitoring. You could think about the way in which healthcare providers are trained in the first place. Almost everything we do is after the fact, because we don't have a requirement of being comfortable with being with an agitated patient as graduating from medical school or nursing school, which means people die of delirium without diagnosis. I really think it should, in the long run, focusing on the clinical provider may be too narrow a perspective. Our system is extremely fragmented. There's almost no respect for maintaining continuity with a given provider. We have a corporate model now of, you get X amount of time with a patient and any provider is interchangeable, even though there's huge evidence that when you change providers, that's an important time of dropout. So I think this will help. But if you really were hoping to get to zero, you need a big global picture.
I agree. Is this on?
This one I know.
So I agree that it's this is just one piece of the puzzle. But what's striking for me is that this piece of the puzzle, even though it's one small piece, still needs a lot of improvement. And I have to say, it's kind of shocking to me that the things that we're recommending that people do here, they're like your 101 stuff. They're very, very basic, and yet they're still not necessarily being implemented. So our project includes both state licensed and state operated clinics, but the focus was originally on state licensed clinics. So these are freestanding clinics with different kinds of culture than state operated clinics. And they actually, just from having been on Learning Collaborative calls, they seem to have more esprit than some of the state operated clinics. So there's a difference there. And the other thing is that this is not just supposed to focus only on clinicians. It's supposed to focus on everybody, but only within the healthcare system. And your New York State is, there are some places like, say, at Kaiser, where it's not a fragmented system. It's just a much more kind of a closed, smooth system. We don't have that in New York State.
Yes, Dr. Harlan.
Hi. I'd like to go back to the Henry Ford study that you put up, because that's very impressive, looking at what happened there. But I'm just wondering, what is your take on what is their active ingredient for what they did right, that everything went down from a high rate almost to zero, and what could we learn from that?
Yeah, so it was actually pretty startling. What they did was that they screened. They screened for depression. They screened for like a single question for suicidality. And then when they identified somebody, they got them into treatment. That's it. And I believe that they also did a little bit of trying to hold on to the person and reach out to them. But it wasn't rocket science. And so if you think about this, like, and so they were, and so I'm not talking about in Henry Ford, like behavioral health. This was all of care. And so if you think about like in primary care, I mean, just a show of hands, how many of you, your last annual visit to your primary care physician had a question about depression or suicidality? Yeah, so we still don't get asked about it. And so that is, it seems so, you know, in a way so trivial, but that's what happened. To me, the kind of then the next step is, so what kinds of treatment were they doing? And I think that they were mostly just doing medication and supportive psychotherapy, but that's it. So I think that that is, I mean, if I were to think about that data, I think that they were kind of, they were like fortunate in terms of like how that data, what happened with their data, that it's kind of not that simple. Like, you know, where there are people who will be identified. We know this. I mean, some of the celebrities that I put up there, they were identified. It wasn't a secret that they were suicidal. They were struggling. They were, they had gotten help. And for whatever reason, you know, it didn't work for them. So we're not going to get to 100% just by identifying and referring.
I believe there was a slide that referred to iatrogenic effects of no suicide contracts, and I was just wondering if you could say anything about that.
About what? I'm sorry?
Iatrogenic effects of no suicide contracts.
The negative effects?
There were, iatrogenic, iatrogenic.
Oh, yeah, so, no, yeah, so so basically, the notion is that no suicide contracts ask for people to make I mean, you could talk about no suicide contracts for a long time, but no suicide contracts ask people to stay alive without telling them how to do it. And so we can do better than that. We can give them some simple tools to stay alive. The other thing is that I actually object to the word contract. It's not a contract. I mean, in order for it to be a contract, both parties have to have skin in the game. And so who has skin in the game with a no suicide contract? The patient promises to not kill themselves. And the clinician promises what? Nothing. And so so it isn't two parties giving and getting. It's like not like I'm buying your house, and, you know, I'm giving you money to buy your house and you're giving me the house. There's, you know, not two people are giving. So, but I think really the other thing is, if you think about asking people to make a promise, you know, it probably has different weight depending on who the person is, who is doing the asking. So if I'm somebody, a stranger to the person in the ED, you know, they've never seen them before and they're never going to see them again, you know, the promise is like nothing. Yeah, can I get out of here? Yes, sure. But if it comes in the context of an ongoing treatment, you know, can you tell me that you're going to stay alive till I see you, or that you'll call me, what, it probably has more meaning, but that's still not a no suicide contract.
Yeah, Ravi.
Hi, thank you for a wonderful talk. As an outpatient doctor, I really appreciated your point that the outpatient behavioral health clinics are where a lot of these patients are. And we're seeing them, and you made an important point about this whole idea that, about following up on missed appointments, which sounds simple enough and is a great intervention, but I'm just curious what you know about how to do that at scale. So we have all these sick patients, and when they're sicker, often they don't show, and you have a busy clinician with a full practice who, they basically freed up 30 minutes to catch up on their notes. But how at a system level do you follow up with those people and re-engage them, especially given that there's no reimbursement for that?
Yeah, so I think in a certain way, it kind of follows up with Fran's comment about the fragmented system. Our system doesn't allow for making phone calls. We don't get reimbursed for making phone calls. But if you think about it, that it's only a very small percentage. We're not saying for every single person do this, but for that very small percentage who are at high risk, who are on your high risk list, you should do this. We did it in the VA for our project, but we actually had people who we hired to do this. So I don't know. I mean, I don't have an answer for you how, those are structural barriers to implementation. It's just like not having a clinic not being able to afford to pay all their clinicians to take 3 hours of training. I mean, those are real structural barriers that, I honestly don't know what to say other than I kind of, for me, like I can tell you for as a clinician, I don't know what you would say other than I put myself out. If I had suicidal people who didn't show up, this is part of my job. And that's how I looked at it, in that I reached out until I found them. And now, that's easy for me to say with this very small private practice, and so it's not the same. And I'm not saying, oh, this is what you should do. It's hard. I'm saying that we have to figure out, if we know that it's something relatively simple, and it's actually not that expensive, and it's probably a lot less expensive than an ED visit, we have to address this as a system. So, I mean, I hear what you're saying, and I don't have the answer, but I can tell you what works and what's important to do.
Deborah?
Just following up on that, when you said that you hired people at the VA to do the follow-up, it's one thing if your primary physician does it, and it's another thing if somebody who's, let's say the primary physician says, oh, of all the people I saw this week, Mr. A and Mr. B need follow-ups, like somebody else is going to make the calls. I wonder if you've looked at whether having somebody else make the calls is as useful, and that, I think, gets to what is the element. In other words, is the element just the contact, or is the element the relationship?
So, so that's a good point. I don't know the answer to that, but because we don't have data on that. I have a suspicion. In the VA, we actually had the person who did the intervention, so they got a safety plan in the emergency department. Our clinicians sat with them, did that, knew them face-to-face, spent about an hour with them. And then that clinician was the person who did the follow-up phone calls. So there was a face, there was a person, they knew who it was. Patients really felt it was incredibly helpful. They were totally shocked that somebody would call them. But I would say that if you have a meaningful phone call with a person, that it could be anybody. I think it's best if it's an ongoing care person, but, if you think about, say, they did have instances where the clinician somebody else did a safety plan and then the clinician followed up. We didn't really notice any differences. I mean, I think the ideal is the person who does it does the follow-up phone calls. Oh, and you know, one of the other things I can say, there's some data that, that shows these like just, and I always feel reluctant to bring up this data because I feel so skeptical of it, but the data are the data, that these caring contact letters that are simply letters to people. It's been a while since you've been in the emergency department. We're just checking in on how you're doing. And call us if you have blah, blah, blah. And that, they have data that shows that those people who get those letters, they have fewer suicide attempts.
Laurel?
Thanks, that was great, Barbara. I understand why the Zero Suicide Initiative started with the mental health system. It is sort of the low-hanging fruit. I wonder if you would comment on which might be the most important elements of this intervention to apply to the non-mental health system, but other populations that we know are higher at risk. For example, physicians.
Yes, so first you have to identify, and then you can think about what do you want to do once you've identified. So the simplest thing is some sort of screening, and then triaging to a higher level of assessment or not, and then some sort of, okay, what do I do when, you know, some sort of referral. So one of the things that, you know, I mean, when we did our project in the VA, we of course did screening, we did the safety plan, and then they got follow-up phone calls, but they had whatever treatment they would normally have gotten. So, I mean, I would say that for non-mental health settings, trying to identify those people who are at risk, first of all, it's the biggest challenge because it's more needle in a haystack kind of thing, and then doing referral for them.
Can I ask a follow-up? So a follow-up to that, there are some in the residency training system that think because of the higher rate of suicide among physicians, it would be a very good idea to evaluate all residents at the start of the year, to both get a baseline and to try to facilitate a connection with a mental health person should that be necessary. And I sort of wonder what your thoughts are about that. It would be a good opportunity, I suppose, to do the CSSRS, which is an interview-based screening, I believe. And then in terms of screening, it might have an advantage, but I wonder what your thoughts are about that.
Doing a mental health evaluation at the beginning of every year, sort of?
Yes.
Do they get a physical evaluation at the beginning of every year?
Nobody's asked me to do that, I'm not sure.
They
Yes,
do.
they do.
I don't know.
So I would say if they get a physical, why not think of it as part of a physical? Like, and I don't mean like the person who's doing the physical, but you know, if you think that it's important to do a physical, why would you think it's not important to do that? I don't.
I think that
Interesting.
this is working. I think the current screening process that physicians do get on an annual basis is kind of a health checklist, and it does ask about depression, but it asks, you know, any trouble breathing, and just like a general review
Yeah.
of systems. And it's not really the kind of in-depth screening we're referring to here.
Well, no, for screening, the CSSRS can be done self-report, and it's in only 6 questions.
Yeah.
And so many places are incorporating it into their general health ratings. It's very, very simple.
Okay, good to know.
But I mean, I don't, you know what, I guess what I would say is, I don't know all the cultural parts, like what's the climate, the culture for doing that? What are the, like, what would be the obstacles? Are the, you know, it's really interesting. I was asked to do a talk at Goldman Sachs in the fall and about suicide. And it's supposedly highly interactive, you know, that, and somebody, and I said, but people are gonna say, like, and they ask about themselves. I said, people are gonna stand up in the audience of 1,000 people and ask about suicide, their suicidal feelings or they say, oh yeah, you know, they talk about depression and anxiety. So there are cultures, even like, I would think Goldman Sachs would not be open, but there are cultures where that's like an okay thing to talk about. So I guess it depends on the climate, but, you know, if it's a huge problem, why not in some way or another try to set the stage for, like, this is an okay thing to talk about.
I mean, on this topic, I'm actually thinking, I just filled out the screening form we had to do last week, so all the residents are doing it right now. And the way it actually asked is if you have a mental health condition or mental medications that might affect your ability to work. That's the way it was asked. So
So
it's
should we
not a very-
sideline you or not?
Yeah, inclusive or whatever. Not really a way people are likely to report, I would say.
That's interesting.
Barbara, wonderful talk. It occurs to me, you stimulated so many thoughts, so if I free associate a bit, forgive me, but it occurs to me that two things I'm aware of over many decade career. One is the vast amount of research that's being done on suicide. And second of all, that as a clinician, nothing had changed for 30 years. What I learned in medical school back in the dinosaur days was the exact same thing that was happening until now. And I think that I think this is really a marvelous change. And I know that the scale has a lot also to do the bringing in of the CSSR. Scale has made a huge difference clinically, and I think this work is the first time I'm seeing that something actually changes. And I was wondering why, and the thought I had, and I wonder if I share the thought, what your thoughts on it was that, you know, we always told people to have to do a better job, but just as you said, we didn't give the suicide person better skills. We haven't been giving clinicians better skills. We've just been telling them do better, but we haven't told them why. And so what it is it ends up being this high-risk thing and a very low sense of self-efficacy. Like, I'm supposed to do better, but I don't know what. So I just think this is marvelous. And so that's a comment, and we're supposed to ask a question. So the question is this, I have to formulate it into a question, is, do you think that that's part of what's been, that there's simply a sense of a high risk and low efficacy on the part of clinicians, and so therefore they avoid it?
Totally. I mean, I think that is an excellent point that it is just like similar to the no suicide contract for clinicians, like don't do it. The thing that I always actually say about with suicidal patients, we tell them, you know, if you get suicidal, go to the nearest emergency room or call 911. And I say, we can do better. Like if you're working with somebody who has panic attacks, would you ever say to them, go to the nearest emergency room or call 911? You would give them skills. And so we can do that with our suicidal patients. We can give them skills. If you think about suicidality as just a state of mind like any other state of mind, yeah, it's really dangerous, but it's a state of mind. And so what do we do with the state of mind in the rest of psychiatry? We teach skills, in essence, in addition to giving medications. But and so I think that your point about like helping clinicians is, I think, is a really important one. That telling them to do better is what we've done. The thing I would say about that is that the advances are not that great so far in terms of what we can give clinicians. You know, we can at least say, look, here's your bare minimum that we want you to do. A lot of them don't. First of all, some of the things that we're asking them to do, which I really and truly believe are bare minimum, feel very burdensome to them, and it's a real shift. And so we have, one of the issues that we deal with is, you know what, my client doesn't want to talk about suicide, and they made a suicide attempt a month ago. They don't want me to ask about it anymore. And so we, so we don't want to interfere with the therapy by asking about suicide. And so there is a lot of kind of education that has to be done. But we haven't progressed in terms of what we can arm clinicians with in terms of, here are the risk factors, like what are the near-term risks? We haven't done really much better in terms of predicting near-term risk. What I think that we can do is help clinicians identify immediate risk, like, are you going to let this person leave the office or not right now? And I think we're pretty good at that. And then what can you do? What can you give your patient that they can help, that they can better cope on their own? And so, I mean, safety planning actually has been one of those things that has been, I think, very helpful to clinicians that go beyond the no suicide contract. So, but we haven't done a lot. And the other thing that I want to say is that, we have these kind of fancy psychotherapies that we've developed and have valid, efficacy data for. But, it's not realistic that clinicians are going to learn DBT and CBT for suicide prevention and CBT for anxiety. It's not realistic. And so we have to kind of, I think, also help them within what it is that they can do. How can they do better?
I will just add that as you were talking, Barbara, I was thinking about the other thing that I think that's different is really putting a systematic implementation lens on how do we change at a, kind of a statewide level and using implementation strategies as opposed to just telling people to do it, but doing it in a very strategic way.
I agree.
Stephen has another question.
So thought-provoking, I've got a couple of questions. One is, I was encouraged that you said New York State proportionately is doing pretty well in terms of, maybe as compared to other states, in terms of percentage of suicides. So I'm just wondering, what about looking at the other side of the scale? What are the states that are not doing so well? What are they doing wrong that puts them at higher risk?
Yeah, so I didn't go through all of the background, like the suicides by regions. The highest level of, the highest rate of suicide is the West. And those are states that are characterized by lots of access to firearms and more social isolation. But I think that if you kind of plot out where we have, in the United States at least, where we have more gun restriction, firearms restriction, and the suicide rate, it's a good map. It's closely aligned. Over half the suicides in this country are still by firearms, and so so I think that those states, given that that's not going to change, they can work on limiting access temporarily, that kind of thing. But we were pretty strict in New York about access to firearms.
But I believe in the slide that you showed that had the states that New York was similar to Texas, which I assume has more access to firearms than we have here in New York.
Yeah, I don't remember where.
Well, that was total numbers, but Texas has a population which exceeds New York State. So percentage-wise, wouldn't we be about the same then?
I would have to go back and look at the slide.
And the other
Honestly,
question
don't
I had
remember.
is, I know Dr. Akendo gave a talk here about should suicide be in the DSM.
Yeah.
That seems like a very simple thing. What is your take on it? Would that be good, bad, or have no effect?
I don't know if it would have an effect on it. I think that now in the ICD, my understanding is that we're actually coding suicide attempt as opposed to just self-harm. I'm not sure. I mean, I guess it kind of dignifies it, and it highlights that this should be focused on separately. Like it kind of like brings it up and out of the other diagnoses. And so from that perspective, I think it's really good. I think that I think the devil is in the details in terms of like, what are the criteria to get there to have that diagnosis? The problem is, so for the people who have made repeated suicide attempts, it probably would be great to have that diagnosis. But half the people in this country kill themselves on the first try. And so we have to kind of do something more than, in addition to, so they wouldn't be on that, they would never have that diagnosis.
Great, well, thank you so much, and I hope
Thank you.
you'll join us for lunch.